In the cardiovascular chapter, we talked about a lot of diuretic drugs that are used to remove excess sodium ions and water from the body. And as we know, that affects a lot of things in the cardiovascular system. Um, Diuretic drugs exert their action through the kidney. They cause increased excretion of water through the kidneys to reduce fluid volume in tissues and blood. And it's prescribed for a lot of different disorders, including renal disease. So any kind of kidney disease, hypertension, high blood pressure, edema, congestive heart failure, liver disease, pulmonary edema, so lots of things. But the site of effect of diuretic drugs is in the kidneys. And so when we get rid of water, we get rid of sodium. Sodium and water go hand in hand. So water follows sodium, or sodium follows water, however you want to say it. It does. So there are lots of different mechanisms to increase urine volume based on the specific drug. So some drugs are potassium wasting and some are potassium sparing. So when somebody, so meaning that they get rid of potassium along with sodium and water, or they keep it. So it's really important for people on diuretic drugs to be frequently monitored by their physician to make sure that their potassium's not getting too low or too high, and that their sodium's not getting too low or too high. So sometimes if you're on a potassium wasting diuretic and your potassium's getting too low, they'll switch you to a potassium sparing one, because as we know, the range for potassium is pretty small in the blood, and if it's too high or too low, it can cause cardiac arrhythmias. Never a good thing. So when your kidneys are not working, when your kidney tubules are not doing their filtration job, and let's say you're on the list for a kidney transplant, you might have to be on dialysis because you have to get rid of some of those things that the kidneys get rid of. And if your kidneys aren't working, then it's not going to happen. And you get toxic pretty quickly. So basically, our kidneys are our filtration and reabsorption system. So dialysis kind of just takes that function outside the body. So we have arteries going into our kidneys that bring the information, and we have veins going out that are with the filtered and reabsorbed blood, basically. And the dialysis kind of just takes that outside the body and has a machine that does it. So dialysis provides filtration and reabsorption. There are two forms, hemodialysis, which is done through your blood, and peritoneal dialysis. And basically, dialysis sustains life during kidney failure. It's used to treat patients with acute kidney failure until the problem is reversed, or end-stage renal failure until a kidney transplant becomes available and is successful. So usually if you're working with a patient that's on dialysis, they're having to go probably 3 times a week. Everybody's a little bit different, but some people, after they come back from dialysis, they are wiped. They are so tired, and they're not going to want to do therapy or even like basic mobility a lot of times. So, but your mileage may vary. Check with the patient, check with nursing, make sure that it's an appropriate time to work on mobility, but it's really important for these patients. So we want to get them moving as much as possible, but we want to honor the fact that they might be really tired after they come home from dialysis. So maybe tomorrow would be a better day because they don't usually have it 2 days in a row. A lot of times in acute care, you'll see people who are in some form of acute kidney failure for whatever reason, and they're working on reversing the primary problem, and they have them on temporary dialysis, basically. So they might not be going 3 days a week on that one. So with hemodialysis, it's done either in the hospital or outpatient in a dialysis center, or sometimes at home with special equipment and training in like a home health setting. Basically, the patient has a shunt implanted, and it moves from the implanted shunt into the artery, so one shunt is in the artery, one's in the vein. It moves from their artery to the machine, The machine exchanged the waste and fluids and electrolytes. There's a semi-permeable membrane between the blood and the dialysis fluid, which is called the dialysate. And blood cells and proteins remain in the blood. So after the exchange is completed, the blood is returned to the patient's vein. So the dialysis port has two holes. It has an artery hole and a vein hole. And so the blood goes from the patient out of the artery hole into the machine, gets filtered and exchanged, and then it goes back into the vein hole. So basically, it's an external kidney. You can kind of think of it that way. It's usually required 3 times a week, and each session lasts about 3 to 4 hours. So they just have to sit there while their blood pumps through the machine. Potential complications: infection from the shunt, blood clotting, blood vessels involved in the shunt can become hardened, sclerosed, or damaged. The patient has an increased risk of infection with hepatitis B, hepatitis C, or HIV if standard precautions are not followed. Hopefully they are. Peritoneal dialysis, on the other hand, is usually done on an outpatient basis. It can be done at night while people are sleeping or while the patient is ambulatory. I remember talking to a guy who was doing peritoneal dialysis, and he said it's done through the peritoneal membrane. That's your semi-permeable membrane. There's a catheter with entry and exit ports, just like there are with a hemodialysis. Implanted, and the dialyzing fluid is installed into the cavity, and then the diastolate is drained from the cavity via gravity into a container. So the person that I talked to, he said he would hook up his dialysis fluid to his port, and then he would go sit in his truck, and he would put the bag on the roof of the truck, and it would gravity drains it into him. And then he would, when the bag was done, he would then go inside and he would sit down and put the bag low, and you hook up to the other port, and then gravity drains it out. So I thought that he had a pretty good system set up, and he said it really worked for him. He said when he sat in his truck, he would read or he would listen to the radio while the dialysate went by gravity. So that is, I mean, for someone who can be on an outpatient basis, that's kind of nice. It can be done at night while the patient's asleep, so that's nice too. So the drawbacks of peritoneal dialysis: it takes more time than hemodialysis. It requires loose clothing to accumulate the bag of fluid, or like the person I talked to had his little system going on. There is a risk of peritonitis from infection. With both types of dialysis, they usually have people take antibiotics prophylactically just to help prevent infection. Any problem occurring in a patient can alter their dialysis requirements. So they might need more or they might need less. So one of the problems with dialysis, it doesn't filter all drugs in your system, so you can get toxic levels built up. So people have to be monitored very closely when they're on dialysis.